Oropharyngeal cancer. This is the anatomy of the oropharynx. Right over here is the soft palate. This is the side and back wall of the throat. The tonsils are right here, and right in this area is back 1/3 of the tongue. The function of the oropharynx is going to be, it is actually part of the throat just behind the mouth. It serves as a passageway for food moving from the mouth to the esophagus and for air moving to and from the nasal cavity. It includes, like I mentioned, the base of the tongue, which is 1/3, the soft palate, side and back walls of the throat, and the tonsils. Tonsils are the most common location for tumors. Their function is to help to trap bacteria or viruses that enter the mouth or nose, contain immune cells that produce antibodies that kill these pathogens before they can spread into the rest of the body. The epidemiology, the American Cancer Society estimated that the U.S. in 2019 has had about 53,000 people will get oral cavity or oropharyngeal cancer. An estimated of 10,860 people will die from these cancers. It's most commonly in men than women, and to be specific, it is more common in African American males versus Caucasian males. And the average age of diagnosis is 62, but can occur in young people, and it is very rare in children. Histology and pathology. More than 80% of head and neck cancers originate in mucous membrane epithelium, and a majority of the oropharyngeal cancer are squamous cell carcinomas. Etiology and risk factors will depend on age, gender, smoking or tobacco use, alcohol use, HPV, poor nutrition or poor oral health, and betel quid and cocta, which is a tobacco leaf. The most common location of spread is going to be in the lungs. Cervical lymph node involvement is also common, and lymphatic drainage by site is going to depend on these: base of tongue into the gigolodigastric, low cervical, and retropharyngeal nodes, tonsillar fossa into the gigolodigastric and submaxillary nodes, soft palate into the gigolodigastric, submaxillary and spinal accessory nodes, and pharyngeal walls into the retropharyngeal nodes, pharyngeal nodes, and gigolodigastric nodes. My case study is a 38 African American female. Her symptoms were back in August 2018. She noticed a knot about the size of a ping ball on her side, on the side of her neck, and she was experiencing painful swallowing, nausea, sore throat, and swelling. Her medical and social history: she was a former smoker. She quit October of 2018. She smoked for 14 years, half a pack per day. She was a social drinker. Patient has P16 positive disease, never used marijuana or chewing tobacco, oral sex limited to one partner in lifetime, and father has HX of hypertension and diabetes. Her diagnostic workup: she saw her PCP they prescribed antibiotics, but they did not work, and the CT scan was ordered. The CT scan was normal, and patient was abnormal, and patient was referred to Emory. Biopsy of tonsil and PET scan was followed. Patient underwent left tonsillectomy. Part of left soft palate was removed, and left neck dissection in November of 2018. Confirmed diagnosis is C09.1. She was stage 1, PT1, N1, M0, P16 positive squamous cell carcinoma of left tonsil. The staging and grading was TNM system. However, HPV-related oropharyngeal cancer does not have a grading system. Treatment of choice depends on the size, site, lymph node involvement, patient preference, and patient reliability and functional outcome. Small primary lesions usually treated with either surgery or radiation therapy, while large lesions usually need a combination of surgery, radiation therapy, and chemo. My patient had surgery and radiation therapy, so she did not have any chemo. She had a few surgeries. She had a left tonsillectomy, hemiglossectomy, and oropharyngectomy, and a left neck dissection. Treatment prescription, she was VMAT. She also had a boost technique. Her dose for CTV was 60 gray in 30 fractions, so it was about 2 gray per fraction. Her PTV was treated with 54 gray, 30 fractions, so 1.8 gray per fraction, 5 fractions per week. She had an OBI daily, and she was a definitive. And this is my prescription or the treatment plan. The critical structures, the right submandibular gland was 15.2, esophagus 22.2, thyroid 36.2, brainstem 9.1, spinal cord 22, left parotid 23.3, the right 6.9, the larynx is 15.1, and the mandibles 26.4. This is her setup. She was she had a head and neck mask, headrest for 20 block, no pad, arms by side with strap, and a red book. And these are my images. And this is where the tumor was, right over here. It just shows the AP and the lateral where the tumor was. And this is my DBH. Side effects and management. One of the side effects, or many of these side effects, mucositis, dermatitis, difficulty with oral nutrition, weight loss. Her pre-weight actually before treatment was 147.8, and post-treatment is 133. Managing with oxycodone and topical medication. Advised to get a PEG 2 placement, but patient refused. The prognosis and survival rate. The death rate of these cancers have been decreasing over the last 30 years. For cancers of the oropharynx and tonsil, the relative 5-year survival rate was 69, but survival by stages isn't available. Follow-up. Patient is doing well and has gained about 2 pounds since finishing her treatment. And these are my references. Thank you.